Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to this latest episode of our podcast, Talking Meds. I'm your host, Jonathan Underhill, Medicines Clinical Advisor here at PrescQIPP. I'm a hospital clinical pharmacist by background and have worked for many years at NICE and before that the National Prescribing Centre. I'm delighted to introduce my guest today. It's Dr. Mark Horowitz. Mark is a clinical research fellow in psychiatry in North East London. He's a visiting lecturer in psychopharmacology at King's College and a training psychiatrist. He's also, you'll probably recognise Mark's name, he's the lead author of the Maudsley Deprescribing Guidelines, those fantastic guidelines that came out about a year or so ago, and they're absolutely brilliant. He also co-authored the recent Royal College of Psychiatrists guidance on stopping antidepressants, and he's also worked with NICE on various of their guidelines, including the depression guideline. He's also quite excitedly been commissioned by Health Education England to prepare a teaching module on how to safely stop antidepressants for the NHS. So what we're going to talk about today is antidepressant prescribing, something that you guys will see a lot commonly in your practice, whether it's in primary care or indeed in secondary care. So I'm going to ask Mark a few questions that I think will have practical relevance to you guys working out there in practice. So Mark, what's your story then, and why have you got such a passion for antidepressant prescribing?
Sure. Thanks for having me on the podcast, Jonathan. Look, I started my psychiatry training and I did a PhD in how antidepressants work at the Institute of Psychiatry in King's College London. And at the end of my PhD, I read a paper about withdrawal effects from antidepressants. And I found that a little bit startling because I hadn't learned about that before in my training. And I had been on an antidepressant at that point for about 13 years. And I thought, look, drugs that cause withdrawal effects also cause tolerance effects. There's no way to avoid that. They're the flip sides of the same coin. I thought, how could a drug that I've been on for 13 years still be having effects if there's tolerance? And I also worried about drugs that cause withdrawal, things like Benzodiazepines and opioids aren't always that good for you in the long term. And so I decided to come off my drugs. I also had a number of health problems that I thought might be side effects of the drugs. And I read all the literature about how to come off antidepressants from some of the leaders in the field that I was working with. And they all said discontinuation symptoms from antidepressants are brief and mild, and you can stop in about 4 weeks, which is very reassuring. And I also, because I'm a millennial, albeit a geriatric millennial, went and read what people said on Google. And they said something very different. They said it was very hard to come off antidepressants, that some people had life-threatening symptoms coming off and it took them months or years. And I didn't quite know which authority to go on, what I'd been taught by professors or what people said online. And I decided to kind of split the difference, and I decided to come off my drugs over about 4 months. It was escitalopram or Lexapro, and I basically halved the dose every month for about 4 or 5 months. I used the molecular biology grade equipment in the lab that I was working in order to make up small doses using liquids and a mass balance. And basically, when I got down to a tiny dose of 1 milligram, my world imploded. I had trouble sleeping. I would wake up in the mornings in full-blown terror, heart beating, palms sweaty, like I was being chased by a wild animal. And I'd be in that state of panic or terror for about 10 or 11 hours of the day. I'd get a bit of relief in the evenings. I was dizzy. Things around me appeared unreal. And it was very frightening. It went on for week after week. And at some point I thought, I can't keep living like this. And I ended up going back on the medication. So I should say 2 things. Number one, that was nothing like the symptoms that had put me on the drugs in the first place. I had been a miserable medical student as a 21-year-old. I'd had all sorts of existential dilemmas, but I'd never had anything like the symptoms I had when I came off the drugs. If it was 3 out of 10 when I went on the drugs, it was 10 out of 10 when I came off them. I went back on the drugs because these symptoms were so unbearable. And essentially, I realized at that point that I was now on the drugs, not because they were helpful, but because I was unable to stop them. And I guess that experience drew my attention to the trouble that people had coming off these drugs, because it wasn't just me. I found thousands and then tens of thousands of people having similar trouble. And it made me realize that the guidance in the textbooks and the NICE guidelines at the time was not accurate. And that's what's led me to do research and clinical work in this area.
Fascinating stuff. I mean, that must have had a massive impact on your life and those around you. And it's impossible for you not then to be, it sounds like a strong word, but biased towards this here because of your own personal experience. And that's where I think you're right. There is a disconnect between what the research evidence said at the time, because that does not reflect what you and thousands of other people were reporting. And now we have a body of evidence that says this is the norm for lots of people who have been on antidepressants for a long time. I think it's probably fair to say at this stage, so the NICE guideline on depression, antidepressants are not routine first choice there. It states in the guideline, do not routinely offer antidepressants as a first line treatment, unless that's the person's preference. So there's lots of other interventions before we get to antidepressants, but we're talking about people who are on antidepressants already, and what do we do about that? So I guess my next question is about why should we think about deprescribing antidepressants then? What is it that triggers that?
So look, there are a lot of reasons why people may want to stop antidepressants. So we know that people generally use antidepressants for long periods of time, and a lot of that use is beyond what guidelines recommend. So guidelines generally say we should use antidepressants for about 6 to 12 months for an episode of anxiety or depression, and only consider longer term use for people with severe and recurrent disorders. In actual fact, there's lots of flaws to that evidence itself, but even taking that at face value, we know that there are 2 million people in England that are on antidepressants for more than 5 years. About half of people taking antidepressants are on them for more than 2 years. So we have an increasingly longer using group of people. Lots of reasons why people may want to stop. Most people are put on an antidepressant in the context of a stressor in their lives, following divorce, job loss, sickness, death of a loved one. And those people are unlikely to have recurrent disorders. Most people move past those setbacks and may still be on the drugs down the track. I run a clinic that helps people to stop antidepressants, and we have people, for example, who had postpartum depression and their children are now in their 20s. So it's long in the past. People may have found other ways of coping. They may have changed things in their lives. And the other main issue is side effects, of course. So side effects are common with antidepressants and can affect life in serious ways. We know that more than half of people on antidepressants will have sexual side effects. We're now learning that some of those side effects may not go away when you stop the drugs, what's called post-SSRI sexual dysfunction, or PSSD. We know that a lot of people report emotional blunting on antidepressants, somewhere between 1/2 and 3/4. That might be very useful in the short term if you're experiencing severe anxiety or panic, but in the long term, we know it can affect people's relationships and sense of self, and it's actually the number one reason people come to my clinic to come off antidepressants. There's also a wide variety of other issues, things like weight gain, daytime fatigue, impairments in concentration and memory. And there is now a growing literature looking at the long-term physical health consequences of being on antidepressants, and they're not insignificant. They include things like increased risks of bleeds, falls, fractures, strokes, cardiovascular disease, and even early death, especially in older people. So these are not drugs that are benign, and if they're not advantageous to people, then we should be thinking about stopping them.
I think that's the key thing. It's that balance of the benefit and risks, isn't it? So, as you say, if you've got an initial stressor in your life, antidepressants can be really useful at enabling you to then access talking therapies, for example, or give you the motivation to do CBT or other things. But they don't work as well on their own as they do in combination with the talking therapy. So I guess it's where do you know when the benefit and risk profile changes, and you can only make that decision on an individual basis. You can't look at population evidence to guide you on that. It has to be an individual conversation with the person taking into account their values and preferences and what's going on in their life now, the classic sort of shared decision-making approach to prescribing and indeed deprescribing of antidepressants. So I guess the next question is, if you've had that conversation with the person and they're thinking, actually, I am quite keen to think about stopping my antidepressant, how do we go about doing that? And what is it that's made us? Because I remember when I was at pharmacy school, I don't think we had the guide, as you just said, the guidance didn't say you need to be careful about tapering antidepressants down. What is it that's changed, and how should we go about doing it?
So I'll just say one thing before I talk about how to come off antidepressants, which is there are certain barriers in people's minds that prevent them coming off antidepressants even when it's no longer indicated. And one of the major barriers that have been found in research is people's belief that depression is caused by a chemical imbalance. If you ask the public, 9 out of 10 people will say depression is caused by a chemical imbalance. That's because we've been inundated through the media, through medical education, that's what causes it. I think people need to be told explicitly that's not what causes depression. Depression is a multifactorial issue. It's related very much to people's lives and what is happening. If people are told, as they often are, they're missing a chemical in their brain and the drug will replace it, who would stop such a drug? If you've got a thyroid deficiency and you're given thyroids, it makes complete sense to continue. Some people have called this description a sort of metaphor, but a lot of patients take it literally, and I think they need to be told that that's not what's going on, so they're able to make an informed decision. And I think they should also understand how difficult it is to show that antidepressants have a bigger effect than placebo in most studies. So I think that there has been, an exaggeration of the effectiveness of these drugs for many years to people. If they make a decision that they want to come off their drugs because they feel that the harms outweigh the benefits, then you're right. There hasn't been a lot of guidance for many years on how to safely come off these drugs. Essentially, what NICE has said is you can come off in 4 weeks, and the way that's been interpreted mostly by doctors and pharmacists is you can halve the dose for a couple of weeks, halve it again for another couple of weeks, and then stop it. Now, that approach is probably reasonable for people who've been on the drugs for about 8 to 12 weeks for short-term use. But many people are on the drugs for years, and that approach is generally unsuccessful. That's been shown now in trials.
Yeah.
It's too quick for many people, and it causes too severe withdrawal effects. And so what the approach now that NICE has put forward, articulated more by the Royal College of Psychiatrists guidance and in the Maudsley Deprescribing Guidelines, is to come off much more slowly, much more carefully, down to much lower doses. So that basically means there's basically 3 major principles. One is to do it much more slowly, not over weeks, but over months and sometimes more than a year. When people take antidepressants long term, their brain changes to accommodate the drugs. And if you stop them too quickly, the brain and the body scream out for the missing drug, and that's what causes withdrawal effects. So you have to go slowly enough to allow the brain to readapt while the drug is being reduced. And so for long-term users, that can be more than a year. The second principle is you've got to go to a rate that the person can tolerate. Everyone's a little bit different. There's not a one-size-fits-all. We've done a little bit of research on what are the risk factors, but essentially the main thing is asking the patient, how are you feeling? If they're starting to have problems, you need to slow down, go back a step and go more slowly. And the third principle is one about going down to much lower doses than people generally do to stop the drugs, because even small doses of these drugs can have very large effects on the brain. And that comes down to something that might be near and dear to pharmacists' hearts, the law of mass action, which essentially says when you don't have much drug in the system, all the receptors are unsaturated or open for business. And so every milligram of drug at low doses has a large effect on the brain. A little bit like the game of musical chairs, when all the chairs, are there and it's easy to find a chair. As you have more and more drug in the system, more and more receptors are saturated, and every extra milligram of drug has less and less effect. So you end up getting this curve, like a law of diminishing returns, that goes up very steeply at low doses and flattens out at higher doses. And that tells us something about how we should come off these drugs, which is It's easier to make reductions at higher doses, and it becomes harder and harder at lower doses. So just to take a tangible example, 2 milligrams of citalopram, which people might laugh at as a homeopathic dose, actually has half the effect of 60 milligrams. So it's not negligible at all. And that tells us we need to go down very carefully at the end in this sort of pattern that's called a hyperbolic taper, where you go down to very low doses before stopping. And often to do that, you need to use things like a liquid version of the drugs to allow people to go down to these small doses. The smallest available tablet for antidepressants in England isn't small enough to allow people to come off the drug safely, either by halving it or quartering it. And also, people shouldn't give these doses every second day, which is often an intuition that people have that'll help people come off more slowly. The problem with that is because the half-life of these drugs is so short, every second day dosing leads to wildly changing plasma levels that can lead to severe withdrawal symptoms. So to put that all together, a simple rule of thumb is to reduce by a proportion of people's dose every month, something like 10% or 20% of their dose, so the reduction gets smaller and smaller, going at a pace that patients can tolerate.
Brilliant, Mark. There's so much in that to unwrap for me as a pharmacist. I'm getting super excited about being reminded about the law of mass action from my days at pharmacy school and pharmacology lectures. Essentially, it's a dose response curve, if you remember, pharmacists, and it doesn't go up in a linear fashion. It goes up really quickly with low doses and then gets to a saturation point. So when you're withdrawing, what basically look at that in reverse, and we'll put something in the show notes just to with a simple dose response curve, just to remind people, and for people perhaps who can't remember their pharmacology lectures. So I love that. I've also heard you say about, in practical terms, you should go as fast as you can, but as slowly as you need. And I love that. I just think that captures it all. As fast as you can, but as slowly as you need. So it has to be an individual response, doesn't it? Just to comment on the NICE guidance as well. So when that was updated in 2022, there is a whole section now, isn't there? 1.412, I think it is, about stopping antidepressant medication. And I was part of the team that was supporting that at the time, because we were getting lots and lots of feedback from people like you saying there was a literature out there describing how we need to be really careful here. And I still don't think it's as helpful in practical terms as it could be, but it's still much, much better than it was. And that's what we always tend to find with NICE guidance. You never end up with perfect, you end up with a little bit better. So again, if you need a reminder of that, guys, it's in the NICE guidance now. So one of the other things, Mark, which I think would be useful to explore, and again, one of the practical issues, and we'll come back to the practicalities of tapering and medicines and stuff, but I want to ask you about that sort of individual response thing. How do you distinguish withdrawal symptoms from a relapse in depression? Because that's the thing that always comes back, isn't it? Oh, I had a patient, I withdrew the antidepressants, and their depression relapsed.
Yeah. Look, this is a critical question. It comes up all the time. You might be aware that there's large groups of patients that leave healthcare and go to online social media groups to get advice on how to come off these drugs. And they're all there for the exact same reason. They're there because they say their doctors and clinicians mistake their withdrawal symptoms for relapse. So it's something that's very common. It's easy to understand why it would happen. If I turned up to a doctor with my symptoms, they would have said in 1 second, look, you've relapsed, you must need the drugs, because I was panicked, I was anxious, I was feeling terrible. So it's easy to see why it would happen, especially when NICE guidelines have for years said withdrawal symptoms are brief and mild. And when people turn up with severe symptoms, long-lasting symptoms, they go, this doesn't match the textbook. So it's an easy mistake to make. Having said that, there's a few clues that can help people to distinguish them. Number one, withdrawal symptoms tend to come on soon after reducing or stopping an antidepressant, can be in a few days. But we actually now recognize that withdrawal symptoms can be delayed for weeks after stopping, probably because the drugs are a bit sticky in the central compartment. There are studies that show the brain elimination half-lives are actually weeks rather than days. And so you can get these delayed effects, which confuse clinicians even more. Probably the most useful way to distinguish withdrawal symptoms from a relapse is the presence of symptoms that were not there in the original condition. So some are very clear. Brain zaps, this little sense that electricity goes through people's heads. Everyone can kind of spot that. Headache, dizziness, they're quite distinctive for withdrawal symptoms. But I would go further and say any psychological symptom that wasn't present in the underlying condition is probably a withdrawal symptom. I'll give you an example. If someone went on an antidepressant because they were feeling lethargic and low and sleeping all the time after the death of a loved one, and now 3 years later when they come off their antidepressant, they're anxious, they're panicked, they can't sleep, it's much more likely that they've developed quite common withdrawal symptoms rather than developed a new onset panic disorder that just happens to coincide with the moment they stop their antidepressants. So I think it's very useful to know what are people's original symptoms and what do they have now, and making that comparison. And I think that takes a bit more digging by clinicians and prescribers. And the last point to help distinguish is if you put them back on the drug soon after they've stopped, generally withdrawal symptoms go away quite quickly. But if you wait longer, it can be much more unpredictable. People get into these protracted withdrawal states that are quite hard to dislodge.
I think that's super helpful. Really, really helpful. Just that notion of I remember I listened to the webinar that you did for the National Polypharmacy Program, and also David Taylor, who I think you work with on the Maudsley Deprescribing Guidelines, talked about it in the webinar we did at PrescQIPP as well. Just that sort of like if it's the original symptoms returning, then that's very different to a new, previously unexperienced or unreported symptom returning as being a key indicator of whether it's withdrawal or whether it's relapse of depression. I guess relapse from depression is quite rare as well, isn't it, Mark? I mean, how often does that happen?
Actually, you know what? I think I'd like to zoom out and answer that because, in doctors' education, probably same with the pharmacists, relapse is very highlighted. It's up the top when it comes to depression, and withdrawal's down the bottom. I actually think it's the opposite. I think withdrawal is the horse and relapse is the zebra, and I'll tell you why. Basically, a lot of depression is seen as a relapsing remitting condition, but that's not true for most people. Most people present in crisis in the context of something going wrong in their lives. And so my quip is it's very hard to have a relapse of divorce. If you're feeling miserable because of something going wrong in your life, it's very hard to have that return. But somehow we've been convinced, that depression through this lens, that it's just like asthma, it's a relapsing remitting condition, and if you stop treatment, it comes back. My point would be, I think life is a relapsing remitting condition, and when it's terrible, we feel terrible, and when it's okay, we feel okay. So I think the vast majority of people do not have relapsing remitting conditions, but we know withdrawal is very common. It happens to at least half of people. If you're on it very long term, it's even more common. So I actually think it should be reversed, as you say. Withdrawal is very common, and relapse is probably much less common. I think that's worth putting in clinicians' minds.
Fantastic. That's really helpful, Mark. Again, just for primary care colleagues, again, one of the things that people potentially struggle with is when should people refer patients who are having issues tapering?
Right. That's a very good question. At the moment, there aren't that many places to go to. So we're trying to set up a national clinic in Northeast London, which has been bubbling along for a while. You might, talk to local secondary care services, but not a lot of psychiatrists are well informed about how to safely taper antidepressants because it hasn't really been a part of the curriculum. You might be lucky with a knowledgeable local person, but at the moment, it's not so easy to know where to point people. There's information around. There's information from the Royal College of Psychiatrists on how to stop antidepressants, which is very useful. There's the Maudsley Guidelines. There'll be some information coming out from the Specialist Pharmacy Service next year. We are trying to encourage interested ICBs to put forward clinics that will be sources of advice. But at the moment, it's a little bit slim pickings.
Yeah, no, I get that. I really do. And I guess when is your Health Education England teaching module due to come out?
It's in review now. I hope in the next few weeks, getting towards the end of a long process.
Yeah. And I guess that deals with lots of these issues as well, does it? In a bit more detail than what we have time for in this conversation here today.
It does. Exactly, a lot of detail.
I just wanted to come back to the fantastically useful Maudsley Deprescribing Guideline that you produced with my old mate David Taylor. So David Taylor, for people who don't know him, um, I did my clinical diploma back in 1993, and Professor David Taylor was one of the teachers on that course. So I'm 56, so that makes David a bit older than me, I think. But if you see him, he looks incredibly young. I was just saying to Mark before, he must have a portrait in the attic that is really old and festered, because David looks great, doesn't he? And really helpful. So I know you two worked closely together on the Deprescribing Guideline book. I guess I just wanted to give you an opportunity to tell people about that, how you came about producing it, because it's important, isn't it, to know about the provenance of anything that we use. And I think it's a really, really good book. But how are we going to convince people that it's a trusted source for people to use? But I guess, what do you do? What was the process for putting it together?
So I should say I've been to David's attic and I've seen the picture that's in his attic, and it's horrifying. So I don't know, whatever he's doing there, he's made a great Faustian bargain. Look, the book came about because David and I worked together on the National Psychosis Unit many years ago, and I knew he'd had trouble coming off antidepressants because he wrote about it. And I approached a lot of different people when I had trouble coming off, and I kind of discovered these ideas about coming off more gently from patients and looking at the neuroimaging of these drugs. And I went around to a lot of people and said, look, I think it makes sense to come down in much smaller amounts, down to very low doses. And everyone basically laughed in my face, all these professors that I worked with, except for David. David said, that's the law of mass action. It makes complete sense, and we should use this. And we actually started using it in the National Psychosis Unit when I was there. We did a lot of deprescribing because people came in with a lot of polypharmacy. And so that very much endeared me to David forever afterwards. Look, we to put together the book, we basically did a literature review of all the relevant papers in the field. We put that together. We assembled a team of psychiatry trainees, consultant psychiatrists, pharmacists to do a whole lot of research in the area. And we developed reduction regimes that were based on hyperbolic tapering, given there's now increasing evidence. So there's no randomized controlled trials that have been published yet about hyperbolic tapering. I should say that. There is a randomized controlled trial taking place as we speak in Australia under Catherine Wallace, a professor of general practice. But there are now increasing numbers of observational studies which show that people who cannot stop antidepressants in the traditional way, halving and then halving again, can come off it if they're given a hyperbolic taper that takes months or longer down to very low doses. And so we presented that evidence, we presented the biological plausibility, and we then went and looked at what liquids, what tablets, what capsules are there for every different drug. We went through every single licensed antidepressants, Benzodiazepines, Z-drug, Gabapentinoids in the UK and even more widely, to look at, if you want to make up a dose of 1.5 milligrams, what's available? Is there a liquid? What are the licensed options? What are the off-label options? And what are the unlicensed options? And we tried to stick to licensed options, of course, whenever we could. And occasionally you need to use an off-label version to make up small doses. And we went through to authoritative places like the NEWT guidelines, for example, on if someone can't swallow a medication, how do you give it to them? And they give very good advice on this drug can be crushed, this drug can't be because of its extended release properties. These capsules can be opened and the beads counted and these ones can't. So we went through drug by drug, basically formulation by formulation, to work out which drugs permit this kind of manipulation to make up small doses. And we give advice and different options for every drug, trying to stick to licensed options. To try to make it really, we wanted to make this very easy for a clinician to put into practice. There is some academic preamble why we're suggesting this, but we wanted it to be someone could open up the book to sertraline, look at the risk factors for the patient in front of them. Some people are high risk, some people are low risk, and say, this is what we're going to do, and this is the drugs we're going to use to implement it. So we wanted it to be very bedside ready. And that's why it's unfortunately quite long, because it goes through every single drug and gives you short, moderate, or fast tapers.
Yeah, I think that's really helpful. There's two things there for me. One is the magic of physicians and pharmacists working together. And I've worked with some fantastic physicians over the years, and when you work together, you do get a synergy. Like I think you've discovered with David, which I think is really good. The second thing is as well, I do lots of teaching to students and GP trainers around one of the things we talk about is where's your background knowledge sources and where are your foreground knowledge sources? So things like textbooks, like the Oxford textbook, Handbook of Medicine and Handbook of General Practice, they would be your background resources where things are fairly stable, but they're really good at telling you the principles of how you go about doing things. And that, to me, I think that's where the Deprescribing Guideline handbook probably fits. The foreground knowledge is where you need to go to places like NICE and CKS because maybe the evidence changes a bit more quickly, and they update their stuff every month or so in response to that evidence. And I guess it's going to be difficult for you and David and others to update this on a regular basis, but those principles are not going to change over the years.
Exactly. I think me and David would both die if we had to update this every month. Probably it's going to be every 3 or 4 years.
Yeah.
I definitely would encourage people to check things in the BNF to make sure that the latest formulation is still there. But you're right. I think that the base rock principles, will be modified by research, but basically the same. So I agree with your formulation of that.
Fantastic. Great stuff, Mark. I think just to close off, I think it would be really useful just if you had your top 3 tips for primary care prescribers. Now, I know we've had this conversation. You said it's usually 8. How about if we do 3 for primary care and 3 for hospital based? Would that help?
That's 3 extra. Will help me a little bit. I'll try to compress it into 3. I think number 1 is if someone stops an antidepressant and they feel miserable, don't jump to the conclusion it's relapse. Just spend some time working out if there's something else going on. It could be withdrawal. Number 2, when people want to come off their antidepressants, so number 2, you should review people, often, and be aware that there are harms to antidepressants. They're not innocuous, and that the effectiveness of the drugs, may not be relevant for people's, ongoing lives. So always paying attention to when you should deprescribe. And 3, when you do help people come off medications, taking longer is better than going shorter, so doing months or sometimes longer. Coming down by small amounts makes more sense. A good rule of thumb for long-term users is reducing by 10% of their dose every month. And you probably have to use liquid versions of the drugs for long-term users to get them off safely. And if you do that, what you'll find is a lot of people that you thought couldn't come off their drugs will be able to come off their drugs. And I'll just say 2 things not to do. That's my way of pulling in a few. Is it's not very useful to give people dosing every second day for most drugs. Fluoxetine is the one exception to that because it has a long half-life. But for other drugs, that causes people a lot of trouble. And also switching to fluoxetine is often recommended. And I think that the evidence around that is actually much more shaky than people think. It is not a free lunch to come off fluoxetine. We know that half of people will have withdrawal effects. The withdrawal effects can be delayed because it's got a long half-life, but people have as much trouble as anything else. So I'm not sure that's great advice. And my tips for hospital-based practitioners, I guess it's the more extreme version of everything I've said for primary care prescribers. When people turn up to hospital and they have severe symptoms, maybe they're pacing, they're restless, they're agitated, they've got akathisia, think about withdrawal states from antidepressants or other psychiatric drugs. We sort of talked about headache and dizziness and brain zaps, but people can be in life-threatening states when they stop these drugs. They can be highly suicidal. Even if they weren't before they started, they can be very agitated. It is worth keeping in mind how severe withdrawal effects can be when people turn up in hospital with these issues. You probably can't get people off in an inpatient unit. That's probably not the best place for people to come off drugs. It probably is about referring them into an outpatient setting to come off the drugs. But maybe for people who start these drugs, it is important to talk about when to stop them. So that should be an important part of the conversation. If you start a drug, you should warn people about the withdrawal effects from the drugs. You should tell them how long they're likely to be on the drugs, when things will be reviewed, and a plan for how to stop. Because we know that people that are given those plans, given expectations that the drugs will only be temporary, are much more likely to come off. Whereas people that are just told, this might be lifelong, or this is going to correct a chemical imbalance, are much likely to not stop their drugs and therefore use them inappropriately. So we can set up expectations appropriately when people start the drugs.
I think that's brilliant, especially that last one. So I was involved in the National Overprescribing Review, and one of the recommendations in there was for guidelines for medicines. When you start a medicine, also think about how to stop it and when to stop it and when you're going to review it as well. And I don't think we can emphasize that enough when it comes to things like antidepressants, because it's much easier to not start an antidepressant than it is to perhaps stop an antidepressant once somebody's been on it for a long time. And it's a classic that we get all the time in the national polypharmacy work as well. It's much more difficult to pull the bath plug out of the bath rather than turn the tap off in the first place. You need to do both, but I think that's really, really helpful, Mark. That's been absolutely super. I don't know if there's anything else you wanted to add at the end there.
Look, I just add one little thing there. I try to get people to come across and observe my clinic, and I encourage clinicians to try deprescribing. I think you do not understand how difficult it is to come off until you've really given it, a careful go, done these things very gradually. I think if people realized how it can take people months and years, it can be completely it can cause complete upheaval in people's lives to come off the drugs. I think that should be priced into the decision to start them. We now know there are lots of equally effective and cost-effective treatments for depression. Withdrawal is not incorporated into the NICE guidelines in evaluating the risk or benefits of different treatments. I think that's a very big oversight for NICE.
Yeah.
And I think when people start to see that would start to readjust when people decide to start these drugs, reserving them for severe cases, for short term if needed.
Fantastic, Mark. That's been a really, really useful, insightful conversation into your life, into your work. Your passion for this comes across loud and clear, and I think that's really, really helpful and really useful. I certainly feel inspired, and hopefully people listening to this do as well. So thank you so much for your time. Please join us again in 2 weeks' time for the next episode in our series on sensible prescribing in older people with Jonathan and Lucy, where I'm joined by Dr. Lucy Pollock, and we meet Brenda, one of Lucy's patients, and we have a really interesting conversation about her. So we'll see you in 2 weeks' time, guys. Bye.